Thank you for that, Lee. So Prakash looks like he's arrived. Prakash Gyawali is going to give us what was to be the first talk, which is the Chicago Classification and Beyond, What's New in 3D. Welcome, Prakash.
Thank you, Peter, and thank you everyone for staying till the bitter end. I feel like Phil Collins and Live Aid, for those who remember, because I've performed in 2 cities today, Philadelphia and here. I was in Philadelphia in the morning giving a couple of talks. Anyway, I'm going to talk about the existing metrics of Chicago classification and what we might have learned since Chicago 3.0. So that's the beyond part. And in the end, we'll spend a couple minutes talking about 3D. So everyone knows the Klaus plot of normal peristalsis. Upper sphincter, lower sphincter are the 2 anchors. You have the skeletal muscle contraction at the top, UES relaxation, smooth muscle contraction, lower sphincter relaxes at the bottom. We use IRP to evaluate EGJ function, especially in the obstructive threshold. Normal thresholds vary with HRM systems. We evaluate esophageal body contraction vigor using DCI, a metric that takes into account the amplitude, the length of the contracting segment, and the duration of contraction. And normative values have been set for low values as well as high. And we have timing of peristalsis, distal latency, normal, generally more than 4.5 seconds. There is one other metric that we use in the Chicago classification. We look at breaks, and breaks longer than 5 centimeters are significant if contraction vigor of the esophageal body is in the normal range. And so if you have long breaks in more than 50% of sequences with intact contraction vigor, that's considered fragmented. Not so when the DCI is less than 450, this is ineffective. So in the Chicago classification, the most important diagnoses we can make, obviously, are the outflow obstructions. So type 1 achalasia, no pressurization. Type 2 with pressurization in 20% or more. Again, all of these have impaired EGJ relaxation with abnormal IRP, higher than the threshold set for the particular HRM system. This is type 3 achalasia, where some contraction is retained in the esophageal body, but contraction is premature and therefore not peristaltic. And then we have these incomplete patterns, EGJ outflow obstruction, where esophageal body contraction may appear normal in the setting of an elevated IRP. This category is very heterogeneous. There are some within this category that potentially are within the spectrum of achalasia. There are others that are structural, and there are others that may not mean very much. Sometimes we find this in patients without particular symptoms. So under the 3.0 classification, you start with IRP. You get the 3 achalasia subtypes based on elevated IRP. If esophageal body contraction is normal or towards normal, you get EGJ outflow obstruction if the IRP is abnormal. All these categories are associated with some form of emptying disorder from the esophagus. And then we have the major motor disorders. In these settings, the IRP is normal, but you have some abnormality of the esophageal body. Either timing is abnormal in diffuse esophageal spasm, contraction is exaggerated in jackhammer, or absent in absent contractility. And these are considered major disorders because they are not seen in healthy normals. And then you have the minor disorders, and these are ineffective motility and fragmented peristalsis. They imply impaired clearance, but they are not pathognomonic of any disorder. If none of these criteria are met, the condition is normal. There are some caveats and pitfalls to using IRP. The first is the phenomenon of LES pseudo-relaxation, where the LES is pulled up into the chest, presumably from a longitudinal muscle contraction. That's what the LES is doing. If you measure IRP at the usual location, you may miss the outflow obstruction. Fortunately, you can move the IRP bars, the IRP box, and follow the esophagus, the LES, into the chest and make a diagnosis of outflow obstruction. We've all learned the effect of opioids. You may make conclusions in the realm of achalasia type 3, diffuse esophageal spasm, and outflow obstruction in the setting of opioid use. The important point there is to not do anything permanent to the esophagus in a patient taking opioids. And then structural lesions. So this is an example of a gastric lap band, but this could very well be a paraesophageal hernia, tight stricture, cancer of the EGJ. Obviously, if there is something mechanical, that can mimic some of the defined achalasia subtypes or EGJ outflow obstruction. We have learned in recent years that the IRP may not be as refined as we would believe. And so there are some settings where the manometry looks like absent contractility, but in fact, if you were to do a flip, you would see an element of outflow obstruction. The Amsterdam group has collected a series of several cases of this kind. We have seen several in our institution. The point here is that if the story doesn't fit the manometric pattern, achalasia is a very profound diagnosis for which therapy is available. So it behooves us to try very hard to make sure you're not dealing with achalasia. And finally, hypercontractile disorders. This entity is interesting because we started out with a limited spectrum consisting of nutcracker. And then we had the HRM metric, exaggerated contraction vigor. Indeed, some nutcrackers fit within this category, and there are indeed some other biases associated with this conclusion. Now, this is the esophageal body dominant pattern of exaggerated contraction. This is esophageal body and LES, and occasionally you'll see an LES dominant pattern. It seems the LES dominant pattern is less common, and there is less hypercontractility, or less numbers of sequences with hypercontractility. The other point to make about the LES in hypercontractile disorders is that it does not make sense to include the LES to try and increase the yield of hypercontractile disorders when analyzing manometry, because the yield of that kind of analysis is very low. Now, what have we learned? We've learned that there is a pre-peak and a post-peak phase in esophageal contractility, and indeed, there are two phenotypes of jackhammer based on this. One phenotype that resembles the normal ratio of pre-peak contraction to post-peak contraction in the esophageal body, and a second phenotype where the post-peak is extremely exaggerated. Obviously, the DCI is higher. We've also learned that high DCI equals more symptoms, usually dysphagia, sometimes chest pain. And if there is abnormal IRP within this context, that is also another reason for these hypercontractile patients to have more symptoms. So it is possible that we can expand the spectrum of hypermotility to include jackhammer with obstruction, because this seems to behave different from the other EGJ outflow obstruction, which is what this would be characterized if the Chicago classification were to be followed. Indeed, when you look at the esophageal body metrics, the only difference between jackhammer and jackhammer with obstruction is that you see an obstructive pattern at the EGJ. And the same biases that apply for the other exaggerated contraction disorders may apply here too. The other hypermotility disorders could include diffuse esophageal spasm, because this also has an obstruction phenotype, that is, type 3 achalasia, which is really DES with obstruction. The same biases, structural obstruction, opioid use, et cetera, may apply for all of these disorders. Why is this important? So with the use of FLIP, we've learned that there may be obstructive physiology in many of these major motor disorders. Everything that is boxed here can have an obstructive element. So if you were to do a flip in these patients, some of these patients would have an abnormal EGJ on flip. So it is important to recognize that many of these motor disorders and absent contractility could have an element of outflow obstruction if studied in other ways. So since Chicago 3.0, what have we learned? We've learned to use provocative testing to try and bring out this obstructive pattern. So this is rapid drink challenge, where you give a patient 100 to 200 ml of water through a straw in the sitting position at the end of manometry. The normal response is inhibition of contraction during the swallows with profound LES relaxation, with or without an after contraction, as you can see in this image. That is the typical pattern, but once in a while you'll see these little slivers of contraction and compartmentalization of pressure. And rarely you will see an overtly obstructed pattern. So the focus on obstruction in patients with dysphagia is relevant, because if you can identify obstruction, then maybe you can do something about it. So these are other abnormal patterns with rapid drink challenge, and indeed the IRP with rapid drink challenge correlates with dysphagia scores like the Eckert score. Others have used test meals to try and define similar phenomenon. So here, a standardized test meal resulted in an obstructed pattern in a patient with dysphagia. In this second example, a hypomodal pattern became more normal in the setting of a solid test meal. The problem with the test meal is it's difficult to standardize, and my nurses at least hate it because it takes up time, it's cumbersome, the patients don't quite like eating with a catheter in place. There is a component of this test meal that may be useful for other reasons. For instance, doing a postprandial study. So if you gave somebody a test meal and followed the patient up for 30 minutes or 45 minutes, you could potentially diagnose some of these mimickers of esophageal symptoms like rumination or supragastric belching or excessive reflux. And that is one of those settings where a test meal could be useful. Indeed, the major motor disorder diagnosis was the only category of diagnosis that was augmented with the use of test meal in a large series reported from Europe. There are other provocative testing that is possible. The impedance bolus height can be measured in outflow obstruction syndromes by using an HRIM or impedance catheter and giving the patient a water challenge. The height of the water column in the standing position at the end of 5 minutes has been shown to correlate with the barium meniscus in a timed upright barium. And the rapid drink challenge can also be augmented by the use of impedance. And the findings on rapid drink challenge may allow segregation of untreated outflow obstruction from treated asymptomatic and treated symptomatic outflow obstruction. Now, what could be common in these outflow obstruction disorders? This was very elegantly described by Peter and Guy Boxtons in 2013, the pathophysiology of spastic disorders in achalasia, where at the one end you have complete neuronal death leading to type 2 achalasia that may develop into type 1, although sometimes you go directly to type 1. The correlates of this are Chagas disease and local and distant neoplasia. But then once in a while you get inflammation and imbalance between inhibition and excitation. That could be the mechanism for different parts of the esophagus to be involved with hypercontractility. Obviously, if the LES is involved and the esophageal body, you get type 3 achalasia. Just the esophageal body, you could have hypercontractility in the esophageal body, and the LES alone, potentially some of these EGJ outflow obstruction with just the LES involved. Again, we have our biases. So this is not a very clean category. Manometry just gives you a pattern of esophageal pressure measurement, and it is left to us to interpret and further refine the diagnosis using alternate testing. Now, the nice thing you just heard about POEM allows tailoring of myotomy in well-defined obstruction phenomena. Let's move over and talk for a minute about hypomotility disorders. Again, impedance helps. And the new metrics that we have learned since Chicago 3.0 is how to characterize or measure the impedance signal. It really should be before the contraction sequence or in the Z1 phase. You really should not see any bolus content in the Z2 phase. Obviously, if it's present in the Z2 phase, that is abnormal. The Z2 to Z1 ratio is the esophageal impedance integral, and this could allow measurement or a means for measuring the impedance signal that you see in hypomotility disorders. So obviously, you have weak swallows, you have failed swallows within the realm of hypomotility. Hypomotility has its own provocative maneuver, the multiple rapid swallow, where you give 5 swallows in rapid succession. Patients who are able to augment their contraction after the 5th swallow of the sequence, when their 10-swallow sequence demonstrates a hypomodal pattern, tend to have a lesser degree of post-fundoplication dysphagia, tend to have a lesser degree of esophageal acid burden compared to those that don't. Obviously, further study of this provocative maneuver is needed. Now, the one additional point that we have learned about hypomotility disorders is that there is a gradient of reflux burden depending on how hypomodal the esophagus is, with absent contractility being the most profound. The pink line here is mean nocturnal baseline impedance. So baseline impedance is a covariate of abnormal acid burden and tends to be lower when there is higher acid burden. You can see that with absent contractility, you are at the extremes. Now, since Chicago 3.0, we've also learned that there is a more severe version of ineffective esophageal motility that behaves a little different from the borderline or the less severe version of ineffective esophageal motility. And fragmented peristalsis seems to be a lesser version of ineffective motility. Now, the multiple rapid swallow responses also follow this gradient. So fragmented is the least severe, and then you have IEM, and then you have severe IEM, more than 7 or 8 ineffective sequences, and absent contractility as at the far end of the spectrum. So using some of these metrics and evaluating, in addition to the esophageal body, the EGJ, GERD classification, or classification of motor findings in GERD, was introduced in 2017. So 3 steps, evaluating the EGJ for intact barrier function, a hypotensive barrier, presence or absence of a hiatus hernia, or combinations thereof, esophageal body metrics within the spectrum of hypomotility, and presence or absence of contraction reserve. Now, we had a symposium last year at Stanford talking about IEM, and the conclusions from that symposium was that one of the more important implications, even though reflux is not pathognomonic or related to IEM, one of the implications of IEM is reflux. Dysphagia is another one, and pre-anti-reflux surgery want to know about hypomodal states. And the basic evaluation for all of this is the standard high-resolution manometry, evaluating primary peristalsis. It is unclear to date if evaluating secondary peristalsis with FLIP, for instance, will provide any gain in this. So it's too early to tell. But depending on what the situation is when IEM is identified, supplementary evaluation could include specific provocative tests designed to determine if IEM is relevant within these specific fields. For instance, if there is bolus transit issues with dysphagia, that could be a relevant point that may need to be factored into how these patients are managed. So FLIP obviously continues to be studied in this realm. Now, I was asked to say a couple words about 3D high-resolution manometry. So what is 3D? So 3D HRM has a little extra recording segment on the catheter. You can see that the sensors for a short segment in the distal part of the catheter are a little longer and look a little different from your standard circumferential sensors. So this is a circumferential HRM sensor that collects data from 360 degrees all around and provides a single average. With 3D, you have sector averaging, so you get 8 separate values for each level. So this can provide additional definition of the sphincter, for instance. And one of the first things that was noted with 3D HRM is that the sphincter, the lower esophageal sphincter, the crural diaphragm and the sphincter, that complex is exceedingly asymmetric, favoring the greater curvature side rather than the lesser curvature side. And you could not pick this out with the standard HRM. So this is one of the conclusions from the use of 3D HRM. The diaphragmatic crural contribution to EGA pressure is higher than previously recognized. Now, Peter and his group have studied this to a great degree. This is the filleted open version of the sphincter from a 3D image, and you can see that the apex of the diaphragmatic hiatus. So that is where that pressure was the highest in the previous image that I showed. That seems to augment with respiration. You can also see different patterns based on whether the measurement is done at rest, in the post-swallow phase, or in the presence of a hiatus hernia. And Peter and his group have been able to separate diaphragmatic crural contribution to the EGJ barrier from the LES contribution, but both seem to be important in predicting abnormal reflux burden. So the bottom line is, this is a technique, this is a technology that's looking for a niche. And so far, all we can say is that 3D HRM is a research tool for the study of GERD pathophysiology at the EGJ at Northwestern. Nobody else is doing this. So in summary, Chicago classification has enabled us to speak the same language. Further updates and refinements are planned for later this year and the next couple of years. Provocative maneuvers and FLIP can augment Chicago classification, especially in the diagnosis of outflow syndromes, and hypomotility disorders are associated with, but not pathognomonic of reflux. Provocative maneuvers can identify contraction reserve. And 3D manometry is not quite ready for prime time. Thank you.